favorite, oh, I'm being informed that the meeting is being recorded. So be forewarned, everyone, you're on camera. So these are the three layers of coverage in Canada. When we talk about Medicare, Canadian Medicare, what we're really talking about is this very first layer. What is required under the Canada Health Act is that every province and territory of this country have a single payer, publicly funded insurance program that covers medically necessary physician and hospital services for all eligible residents of that province or territory, period. What is Medicare? It's insurance for doctors and hospitals, full stop. Anything that is provided over and above that is not required by the Canada Health Act or the federal government. And that is what explains why those of you who live in Ontario may be aware that we have, for example, publicly funded drug coverage for seniors over the age of 65 rather. But those of you who live in BC will know that that coverage for people over 65 is income tested. And so there's a wide variety of coverage of things like physiotherapy, home care, dental care, pharmacare. All of these things vary from province to province. How is it that that's possible under a publicly funded so-called single tier insurance plan? The answer is because that stuff's not doctors and hospitals. And so that is how we end up with the kind of variation that we have in what we call layer 2, which are clinical programs and services that for which there is a mix of financing. There is some public coverage for some people under some circumstances. There is some private coverage through people's employers often in certain circumstances. And then a whole lot of people are paying out of pocket for these services. And as a family doc, and those of you who practice in the healthcare system as prescribing providers will attest to, one of the first questions I need to ask my patients when I'm writing a prescription to manage whatever their condition might be is whether they've got drug coverage or not, because that's going to determine how likely that person is going to be able to follow through with the treatment plan that we're negotiating. And then finally, in layer 3 are all of those that are primarily privately funded. And that includes a wide range of things from dental to vision care to outpatient physio. I mean, when we decided to build Canadian Medicare, for some reason, we decided that the mouth is not part of the human body and we excluded dental. But in fact, you know, these are simply policy choices that we've made as a country. They're not necessarily good or bad. They reflect decisions that were made over the course of history that we're now living with. And all of it is consistently up for grabs and up for renegotiation. So I've told you that more than 90% of Canadians view Medicare as a source of national pride. And it's interesting to think that a set of public insurance plans could be the case. But I'm going to pause here and ask people to write into the chat what you believe, in spite of that pride, our greatest struggles or problems or challenges in Canadian healthcare were prior to the global pandemic. Taylor says, so people are already jumping all over wait times. And of course, we will talk about wait times, absolutely. What else? Fee for service. And Carolyn from UBC, can you tell us a few more words about what you mean by fee for service?
Well, physicians are compensated for piecework. It's like working on an assembly line, and it's not connected to the whole patient. It's not connected with the precursors and the consequences. And it's really counter to whole person care.
Excellent. What else? What are some of the other challenges? Taylor is saying access. And what's interesting is that, you know, wait times are often used as a proxy for access. So, but of course, you know, some things are, for some things, the wait time is essentially infinite, right? And therefore a wait time is not always a perfect indicator. And Mariana is saying access to a primary care provider. Absolutely. Sophie mentions mental health and Alessandro talks about drug coverage. Laura mentions Indigenous health inequities. And Malcolm is talking about the fragmentation between the private, public, and quasi-public long-term care. And we will, I hope, have some time to talk about long-term care today. R. Cormier talks about cultural appropriateness, and I would talk also about cultural safety in that realm. coordination, and racism. Excellent, all really important observations. So I'm going to share with you some work that colleagues and I did not long ago. This is a piece of work that was published in the Lancet in 2018 that was sort of an overview of Canadian health systems. And I'll tell you what we picked on the basis of our review and understanding of the evidence as the three most important challenges in Canadian healthcare. The first was that wait times for elective care are too long. And the second is that services outside the traditional Medicare basket, outside that top first tier that I mentioned that's primarily publicly funded, are often inaccessible. So that includes access to mental health services not provided by a physician. It includes access to pharmaceuticals. And the third is Indigenous health disparities. So I'm not saying that we were right. I'm saying that these were our picks, and you might all disagree. One of the questions that I would have for you, and I'd invite people to unmute themselves if they wish to comment, is what do you think has happened on these three issues during the global pandemic? What have we learned as a result of COVID-19 around these three things?
Well, for sure, they've gotten worse. I would say or vote from what I've noticed. I know elective care for a fact has gotten canceled in a lot of circumstances, pushed further. And I'm also sure that underserved populations or out of reach populations, including Indigenous health and those kinds of disparities, homelessness, all of that has gone downhill as well.
Excellent observations, Taylor. What else? Anyone else want to jump in? So I'm going to agree with Taylor. And I know that you mentioned that your previous speaker had made some observations about what have we learned that's positive as a result of the pandemic, but also what have we learned about what's negative. And we'll come to what's positive. But I do want to say my colleague, Dr. Nadine Caron, and I had a piece in the Walrus last summer in which we talked about these pre-existing cracks in the healthcare systems of Canada becoming chasms. And for those of you who don't know Dr. Caron, she's an extraordinary human and amazing scholar and physician, one of Canada's first Indigenous surgeons, and practices in BC. And some of you may have had the opportunity to work with her. One of the questions is what happens to the weaknesses in a system when under stress? And sometimes, we manage to kind of pull together and pull it off, and places where you thought, links that you thought were weak in the chain actually become reinforced under stress. But in this case, our view is that all three of those challenges that I've just outlined for you have become worse. So I'm going to say a little bit more about that. You may remember the news coverage from Northern Italy as we were embarking into the first wave of COVID-19 and the first cases were starting to hit North America. Those horrendous scenes of healthcare providers exhausted, working 48 hours straight, not enough oxygen, not enough ventilators, not enough ICU beds. People, clinicians having to choose between which patients would get access to life-saving ventilation or medications, not dissimilar to what we've been seeing happening in India over more recent weeks and months. And we were terrified, all of us working in healthcare and all of us living in Canada, about the possibility of such a circumstance coming to be here. And I think we had lots of good reasons to be worried because we were already starting out with systems that were overfull. I mean, in my own home province of Ontario, all of the news coverage of our hospitals was about hallway medicine. We already had hospitals that were overfilled and packed with patients well past 100% capacity. And we thought to ourselves, how on earth can our system deal with a crisis of this magnitude? If people start flooding the hospital system, we will surely go under. And we pulled together. And we did manage to avoid that catastrophe. And when I say we, I don't just mean hospitals, although hospitals did do a lot of work for better and for worse, to move patients out of the hallways, to move them out of the hospital. People were sent home with supports that they never would have been able to get in the months leading up to the pandemic. Huge amount of work was done to ramp down elective care to make space for people to come into hospital beds and ICUs. A whole lot of community-based care was suddenly made available that hadn't been available previously. And we managed to absorb the shocks of all three waves of so far of this. I mean, some of you may be in Manitoba still experiencing the third wave, but so far we haven't had that Northern Italy crisis. We haven't had that India crisis. We haven't had that New York crisis that we were all working so hard to avoid. And so in that sense, we wanted to declare victory. The problem, of course, was that our eyes were so narrowly focused on that ball of not having hospitals become overwhelmed that we completely missed what was happening around us. And that was this: all of the other impacts of the pandemic, the horrendousness of the impact in long-term care. Most of you, I'm certain, will know that over 80% of our deaths in the first wave occurred in long-term care facilities in Canada, a much higher proportion than in just about any other country that I'm aware of. Horrible mental health effects that are continuing to linger, not only among adults, but also among youth. And then, of course, the economic impacts of the shutdowns, with people being laid off, people losing their homes. And of course, as we know, the first thing that you lose when you lose your job in this country is you lose your drug coverage, you lose your mental health coverage, you lose your coverage for all of those things in that second layer that we described earlier. And so inadvertently, in putting in place those strict public health measures and closing down the economy to try to prevent hospitals from becoming overwhelmed, we created other problems, ripple effects in other parts of the system that the systems that underpin or undermine health that I think we will be feeling for decades to come. So what happened to our three problems? Well, we said wait times for elective care were too long pre-COVID. And as we all know, in order to make room for COVID, we had to shut down a whole bunch of elective services. In my own hospital today, we're still well below 50% of our pre-COVID volumes for elective surgery, and just looking to be ramping up in the coming weeks. So the estimates of so-called backlogs or large amounts of deferred care are very significant. And we're going to have to think long and hard about how we're going to overcome that, because the reality is, remember, we talked about the importance of public support for a program like Medicare. If people were already waiting more than a year to have a hip or a knee replacement pre-COVID, and now we've had to cancel thousands of surgeries across the country, how will we make sure that people can access their care in a reasonable enough time frame that they will continue to feel supportive of this social compromise that we have struck around trying to ensure equity in the way that we use our healthcare resources? This is just a table from a modeling paper that came out in CMAJ back in November around the surgical backlog. I mean, the point is, every week that went by in the first wave, and this is only in the first wave, you saw a week over week increase in people on the wait list for surgery. And in fact, it's hard to know really what the true wait times or wait lists are, because so much of the pool of unmet need has yet to kind of declare itself. And so there will be much more. And this is only surgery. We're not even talking about outpatient specialty care, non-procedural appointments. We're not talking about mental health care. And we're certainly not talking about all of the deferred care with respect to management of chronic disease, diabetes, childhood immunizations, and all of these other ways in which we try to keep people well in the system and prevent them from having complications of their disease that lead them to the hospital. The second challenge was that services outside Medicare are inaccessible, and pharmacare and mental health care were two examples of that. A lot of work has been done around these questions. It was estimated in wave one that Canadians became twice as likely to have lost their prescription drug coverage as to have gained it over the past year. Remember that we have millions of people in this country who have functionally no drug coverage at all. And that as a result of the loss of employment from the economic slowdowns, that it's been extrapolated that there could be a very significant increase in mental health issues and concerns. Parenthetically, alongside this are other epidemics that have made themselves known, for example, in the realm of intimate partner violence. We know that when economies slow down and money gets tight, that all kinds of ill effects, whether it's addiction, whether it's violence, and the sort of unraveling of the safety nets that we build for each other in our families and our communities becomes a really real problem. And those are things that we're going to be feeling, I think, many decades to come. So this just refers to the number of people who don't fill their prescriptions as a result of cost. And the reality is in Canada that we have huge numbers of Canadians who do not fill their prescriptions because they can't afford to do so. And this was a problem before COVID. It's more a problem now, I would say, than ever. And as money gets tight, one of the first things that people do is they stop filling their prescriptions. Why? Because it's more important to them to pay rent. It's more important to them to feed their kids. And so, faced with those kinds of choices, people will make absolutely legitimate and rational choices, but those are choices that will have long-term ramifications on their health if they're not taking their blood pressure medicine, if they're not taking their diabetes medicine, if they're not taking their puffers for their chronic lung disease. The risk that they experience avoidable complications of those diseases that can have catastrophic effects on their health and the well-being of their families is really real. And then finally, a few words on Indigenous health. I'm not myself an Indigenous person. I'm a settler on these lands, but I will say that I have learned a tremendous amount from my colleagues, my Indigenous colleagues, on these issues. And I think, the reality is that as hard as COVID-19 has been, we already had an epidemic, a pandemic that this country was experiencing pre-COVID, and it was the epidemic of addiction, opioid addiction, and opioid deaths that has disproportionately affected Indigenous communities in this country. And this really challenging issue came to a head in ways that most people were not expecting and did not do much to prevent over the course of the pandemic. When you isolate people and when you disrupt the supply of safe versions of the drugs that they are struggling with dependency on, it turns out you put their lives in danger. And we've seen a huge rise in opioid deaths. Those of you who live in BC will have been following perhaps some of these numbers, and disproportionately so among First Nations people. This is just a different pictorial of the same thing. So, the waves of COVID, we've seen 3 so far in this country. I would not rule out a fourth. It's been interesting to see how they have pointed us to the social determinants of health. In that first wave, as we've discussed, it was our elders who bore the brunt, not only because older people are more likely to have comorbid illness, but actually because of the physical environments in which we have warehoused our seniors in this country in long-term care, and the unacceptable working conditions in which we have placed those workers who work in long-term care. If you can't earn a living, you can't make a living wage at one job because it's a part-time contract job with no benefits at minimum wage, then you're going to hold down 2 or 3 of those jobs. And by forcing people to move back and forth between long-term care facilities and their employment, and Ontario was slow to close this down, as compared, for example, to British Columbia, there are very real consequences in terms of the rate at which infection can spread from one facility to another and can spread through those workforces within a facility. The second wave is when we saw essential workers hit. And by that, I don't mean essential workers in the healthcare system, I mean people who work in factories, in meatpacking plants, in Amazon distribution centers, in grocery stores, on construction sites. These are people who do not have the option to work from home and who do not have the option not to go to work because they need to earn a living. And in wave 3, we have seen very hard hit communities, racialized communities, low-income communities in our nation's urban centers. And so these waves, I mean, the characterization is not complete and it's imperfect, but it points us to what we all know to be the case, which is that this is not just a pandemic. It is what has been called a syndemic, a synergistic pandemic. 2 forms of pandemic happening simultaneously. The first is the pandemic of the COVID-19 virus. The second is the pandemic of comorbidities that makes people more likely to die of the virus and of the likelihood of contracting the virus as a result of the social situations in which they find themselves. In other words, it is a pandemic of poverty and inequality that has layered on top of the pandemic of the virus to hit more significantly those communities who are least likely to cope. And that is the situation that we find ourselves in. It's not a unique Canadian story. Versions of this have been playing out all over the world. But if we think about healthcare improvement, which is what this group is interested in thinking about, we have to ask ourselves then, what have we learned as a result of all of this? And therefore, what are we going to do about it? A few words about the vaccine rollout. Those of you, some of you may recognize this map. We have seen just the same kinds of disparities in vaccination in the rollout, not just in the city of Toronto, although, you know, as Canada's largest city, certainly a lot to learn from the Toronto experience, but also all over the country. Who got the vaccine first? Who got appointments booked online for the vaccine at well-performing, you know, high-efficiency clinics, and who had to stand in lines like this one? This photograph was taken at a vaccine clinic run by my own, not run by, supported by, in partnership with others, my own organization. People lined up for 6 and 8 hours. They camped out, you know, in chairs on the sidewalk overnight in the rain in order to get access to a vaccine. This is in the Jane Finch corridor, one of the lowest income neighborhoods in the city of Toronto. In the city of Toronto, Canada's largest city, there was a direct inverse correlation between the income of a neighborhood on the one hand and the rates of COVID-19 and rates of vaccination on the other. In other words, you know, the more you needed a vaccine, the higher your rates of COVID in your neighborhood and the lower your income, the more likely it was going to be difficult to get one. And that is something that we're all going to have to come to terms with. So the question is then, as we find ourselves in this moment of crisis, how do we locate the opportunity? And the good news is, as much as we've seen a deepening of these pre-existing cracks in our health systems, we have also seen some amazing, amazing opportunities. You've spoken already in your previous keynote speech, I know, about the massive overnight conversion into virtual care and telemedicine. You know, some of that needs to come back to the in-person world. Some of it isn't best delivered through virtual means, but lots of it actually can be delivered virtually in the go forward. And for many of our patients, including low-income people and people who are hard to serve, this is actually a much more convenient thing than having to take a half day off of work to navigate yourself to a doctor's office, to sit in a waiting room for 45 minutes so you can get 7 minutes of FaceTime with somebody. Really thinking about how we can enhance our work in the virtual and digital realm to support underserved communities is one of the great opportunities post-pandemic. My own organization has been working on this. We've launched what we call Canada's first virtual hospital, Women's Virtual, in which we talk about the integration between in-person care and the wide variety of different ways of providing care virtually. Virtual care does not mean a FaceTime call with your doctor. Virtual care can mean any number of things. It can mean that you're prescribed an app and a series of questionnaires that you'll be using to monitor your own mental health and adjust your exercise, your lifestyle, your therapy, your medications in accordance with the feedback you get. It can mean that your family physician or your primary care provider has an e-consultation with a specialist or a phone consult with a specialist, and you never see the specialist yourself. Instead, they're able to get advice. You don't have to sit on a waiting list for 6 months, and your primary care provider can implement that advice along with you. It may mean that you have an email interaction or a secure text message interaction with your provider, but it's someone who knows you and has an ongoing relationship with you. And when what is needed is in-person care, it should mean that you get that too. So we're not talking about building parallel systems of convenience, app-based, divorced from relationship services. A true model of virtual care that has health as its goal integrates all of these tools, including the in-person tools, in order to better deliver for people. What else has happened that's good? Well, lo and behold, mental health is finally on the agenda. And one good thing about mental health services is that quite a lot of those can be provided virtually, whether synchronously or asynchronously. And we've seen a huge investment, a rapid investment by governments across Canada in significant virtual mental health services for Canadians. I don't think that's a genie we will put back in the bottle. And I think we may find that one of the lasting legacies of this pandemic will be better access to mental health services for Canadians who don't have private insurance. We've seen a huge shift in the conversation about income supports. Finally, with the CERB and other income supports that have been put out by the federal government in this pandemic, we're no longer talking about welfare-based approaches to income supports, but rather about topping up people's incomes in ways that are rapidly responsive to their needs. And this is something that I think will be a game changer for health in Canada. Probably, I would actually say, the most important health intervention of this whole pandemic has been the CERB, which has stopped hundreds of thousands of Canadians from losing their apartments and from losing their ability to feed their families. And so I don't see how we can possibly go back to a time when income supports are revert back to their previous structures. And finally, we've seen extraordinary leadership from Indigenous communities across this country. You know, in the first wave, when we thought about how COVID-19 might affect Indigenous communities, especially in rural and remote on northern reserves, I think people were terrified that these were populations that were sitting ducks for horrible outcomes. Lots of crowded housing, not a whole ton of access to services, huge rates of those non-communicable comorbidities that we talked about, such as diabetes and heart disease. And it was felt that actually, you know, if COVID-19 were to come onto reserve, it could be truly devastating. And instead, in the first wave, what we saw was extraordinary exercise of self-governance by these communities. They sealed their borders in ways that I don't think any of us expected could be possible. They kept their elders safe, something which the rest of us could have taken a page out of that book. And we saw incredibly low rates of COVID-19 in the first wave. Having said that, as you've heard, there were other ripple effects, particularly around opioid deaths, that I think we would do well to think about, but nevertheless, really inspiring exhibit of self-governance. So ultimately, what we've learned from this pandemic is that the pre-existing cracks have not gone away. They have revealed themselves to be much deeper than perhaps we realized. And yet at the same time, we've also learned that we are able to change. We are able to improve our health systems, and that we are not beyond the kind of progressive vision for healthcare that those of you who believe in health system improvement would like to see embraced. And so with that, I will stop my screen share and try to engage you in some dialogue.
Thank you so much, Dr. Martin. I'm just waiting for some questions to come in, but I as always, have some myself. My first one that I was wondering is about the hallway medicine in healthcare. I know that it was a major issue before the pandemic, and you spoke to it that when we kind of rerouted the elective surgeries and stuff like that, we were able to kind of alleviate that stress a little bit. But now that we have to bring back all these elective surgeries and possibly at like a higher or faster rate, do you think that's a challenge we're going to face at like
Yeah.
even worse?
Great question. And the answer is, luckily, most of the hallway medicine problem and most of the high occupancy of Canadian hospitals is not due to surgery. It has been traditionally attributable, I mean, to many factors, of course, but a prime one amongst them being what we call ALC, or alternate level of care patients. So these are people who have been admitted to the hospital, often frail elderly people with chronic diseases, who are not strong enough to be able to go home, or put another way, we do not provide enough services to them in the home to make it possible for them to safely go home. And therefore they get put on wait lists for long-term care. But there are no beds in long-term care. And so they sit and they wait in the hospital. And in many Canadian hospitals, more than 20% of the beds are occupied by people in that category. ALC patients, meaning that they do not have any acute medical need. They are not receiving hospital level care, but they are occupying hospital beds. And of course, every day that an older person who's frail lies in a hospital bed, they get weaker and weaker, and it becomes more and more impossible to ever get them home. So one of the things that I think has been good about the pandemic is that we've managed to figure out that actually it is cheaper and better for people if you get them out of the hospital and get them home. And if that means you have to invest in more community-based services, then that's what it means. And I do hope that that will be one of the lasting legacies of the pandemic, is improved care, whether it's through remote home monitoring, whether it's through in-person home care services, or some combination of those things, to try to get people home when they come into hospital, or better yet, to prevent them from coming into hospital in the first place, caring for them better in their homes so that they don't end up waitlisted for long-term care until and unless they and their families decide that that's really what they want. And then the route should be from home to long-term care, not from home to hospital, stay in the hospital for 6 months, and then move into long-term care.
Thank you. Yeah, I think that makes a lot of sense. We have a question from a couple coming in, one from Alessandro saying, what are some challenges to universal basic income in Canada? It seems so straightforward, but there must be some obstacles that remain.
Sure. Well, I mean, there are many obstacles. One is, of course, the price tag. And depending on how you design a basic income program, whether you think of it as a truly universal program in which every resident of the country receives a check, and then some people have it essentially taxed back, which sounds like a huge amount of money, or whether you think of it more as a top-up. In fact, we actually already have a universal basic income of the top-up variety in Canada. We have it for seniors in the form of old age security and the guaranteed income supplement, which is one of the reasons why our rates of elder poverty in this country are so low, is because of that combination of programs. And we have it for kids in the form of the Canada Child Benefit, which has been slowly built up and enriched over time. And remember that although it's fashionable to say we have it for kids, the reality is that we don't give money to kids. We give money to families with kids. And so when you lift a child out of poverty, what you're actually doing is lifting that family out of poverty, and the effects on everyone in the household are then felt. And so, I agree with you. I don't think it's such a big deal. I think that one of the things that is interesting to ask oneself is, who's left then? If we're already doing this for seniors and we're already doing it for families with kids, then what we're talking about is mostly single working people, often in that category of folks who are in the essential worker realm, people who are working low wage jobs and not managing to make ends meet. And I guess the question to ask yourself is, who's voting to help advance the interests of those people? Because right now, actually, we've created a perverse system in which it is harder to get help from government if you are a member of the working poor than if you simply give up working altogether. And so I agree with you, Alessandro. It makes a lot of sense. That doesn't make it politically easy to do.
Thank you. Another question from Carolyn Canfield, UBC. She says there's a tremendous political and organizational inertia in the 3-tier healthcare system. Who will lead change that addresses reducing inequity? You spoke to this a little bit. What will keep us from breathing a great sigh of relief and go back to what we pretend is life before COVID?
No, I couldn't agree more, Carolyn. I mean, this is the thing that keeps me up at night. It keeps me up on the micro scale, like in my own organization. All of these people who have risen to the occasion and done extraordinary things that never looked like their jobs before, you know, going out on mobile into shelters to do swabbing and vaccinating and running remote home monitoring programs and, you know, doing things that aren't traditionally thought of as doctor work or nurse work or whatever, just doing what had to be done, everyone in partnership together, like thinking differently about resources, doing without, doing with less, making it happen. And, you know, they all just can't wait to go back to their regular jobs and just like pick it up where they, you know, I mean, don't we all yearn for some, you know, nostalgic vision of what we think we had before? It's a natural human instinct. People are tired, but actually it would be a huge missed opportunity to have those people all go back to doing things the way they used to do them. What we want is to try to gently and respectfully bring them back to something different. So on the micro level, I worry about it. And on the macro level, I mean, of course, how can we not? I mean, never mind some life before COVID universe. If we're not careful, we're headed for austerity. It's going to be a whole lot worse than life was before COVID if we're not careful. Because as we all would acknowledge, we've had to spend a lot of money to prevent, you know, everything from falling apart over the course of this pandemic. So what is the route back fiscally for governments that want to see things improved for people is going to be like, that's a global conversation. It is not just a provincial or a federal conversation in our own country. And I think it's going to be really telling, coming back to this thing about how we design our programs is an expression of what we value. It's going to be really telling to see how we resolve those tensions.
Thank you. Another one from Elizabeth from University of Toronto. I actually wrote this one down too, Elizabeth. How can we ensure that virtual and telehealth care services will be provided to communities that need it most, especially if they already do not have a high level of access to the internet?
Well, this is a many-layered of a question, and I salute you for the question, Elizabeth. It's a great question. On the one hand, at a superficial level, it's not superficial, at first glance, it's true that there are places in this country where there is no broadband access. And there are places in this country where there still isn't good cell phone access. So, you know, designing fancy virtual telehealth services that depend on broadband internet is surely not going to work for everyone. And it may not work for some rural and remote communities. And it may even not work for some low-income people in urban centers who are, you know, have been experiencing trying to do work from home and online school for the last year on a spotty internet connection. However, that is only one slice of the pie. You know, we also need to acknowledge that actually telehealth is one of the greatest Canadian innovations in the history of healthcare for rural and underserved and remote populations. I started my career in rural Northern Ontario. Ontario Telemedicine Network was the most unbelievable innovation imaginable for those communities, to be able to access a specialist without having to fly out of your community, just by going to the local nursing station and logging into one of these clunky old boxes that we used to use for OTN. You know, the ability of people who live in rural and remote areas who would never have access to that kind of specialty care, to be able to access it through telehealth, even if you don't have, you know, you're not doing it on your fancy, you know, handheld device, is an extraordinary innovation when it's designed well. Remember also that for people who don't speak English as a first language, using telemedicine and virtual tools is an amazing way to be able to do simultaneous translation and give people access to services in their own languages. And finally, I will remind you that there are huge numbers of people. I'll talk for a moment about urban populations in cities like the one I live in. People who don't have drug coverage, who don't have private insurance, who can't afford to take a half a day off of work to see a doctor, almost all of them have got a phone. And so actually, you can design health services using virtual tools. They don't have to be fancy video ones. It can be something called your cell phone, your telephone. It can be text messaging. People are communicating with their families back home all over the world on those devices. We're kidding ourselves if we think that it's only wealthy, white people in Rosedale who have access to these tools. People are using them across all income levels, all over the country and all over the world. The question is, are we designing the services right to reach them? Are we designing them in ways that are accessible for people? And so broadband is a symbol of that. Of course, if people can't even access the internet or can't even access the phone, or you have to get them a phone in order for them to be able to use it, or a tablet or whatever, then that's step one. They have to be tech savvy enough to be able to use it. But actually, for many people, opening up telephone options to be able to speak to your doctor on the phone rather than taking the day off of work is a tremendous improvement in access for a whole lot of people who struggle to access health services. And so the answer is it can cut both ways. And so it depends is always going to be the answer. It depends on how you design it, and how you design it depends on who you care about and what you care about. And that's up to you to figure out how to design those services well.
Thank you. There's two more questions here. One actually came in from the telephone, but they messaged me here. It says, can you please ask Dr. Martin about the differences in vaccine hesitancy in lower income neighborhoods versus higher? They're wondering if there are any unique trends.
Sure. So I'll say, again, this is another great and multi-layered question. On the one hand, weren't we so quick to label racialized people and poor people as being vaccine hesitant when actually we just weren't bringing them any vaccine? I mean, you all saw that lineup. We've all seen the lineups of people, by the hundreds and the thousands lining up. And in fact, we in the city of Toronto have just finished a sprint in which we did extensive and deep mobile outreach to underserved postal codes in the city. And lo and behold, those hotspot neighborhoods now have higher vaccine rates than the rest of the city. So actually, I wouldn't call it vaccine hesitancy to begin with. I would call it lack of access to services. And I think we need to be careful about assuming that health literacy is poor, or that people don't want. If you're putting your vaccine clinic at the convention center and expecting people to get online, book themselves an appointment, take 2 buses and half a day off of work to get there, and you close at 6 p.m., then that's true. People aren't going to take the vaccine. I wouldn't call it hesitancy. Having said that, it is of course true that people who come from communities who have been abused by the healthcare system, and I use that word advisedly, whether it's racialized communities, whether it's Indigenous communities, to name a few, of course, those people will have an absolutely good reason to wonder whose interest is being served when somebody shows up at their door with a needle. And they are right to wonder about that. It is not outside the realm of collective memory that people have shown up at the doors of these communities with, claiming to do something that is good for your health, and in fact have shattered families and communities for generations. So, the answer to that is not, I don't think, to say, well, I guess these people are hesitant. The answer is to engage the leaders in those communities to bring the solutions themselves. And so we have had a very successful Indigenous-led vaccine strategy in my own province and my own city, led entirely by Indigenous healthcare providers. We have an amazing set of clinics that have been hosted by the Black Health Alliance and the Black Physicians Association of Ontario, reaching out to Black communities across the city. And so, the answer to the hesitancy is not, I mean, it's the same as answer to hesitancy in any community. You bring people the information, you improve their literacy, you answer their legitimate questions, but you bring it to them through leaders who they trust and know, rather than bringing it from some external force and expecting that people are just going to trust because, you know, I've got the letters MD after my name, therefore I must know what I'm talking about. And I think that's the journey that we're on.
Thank you so much. That was an excellent answer. Do you have time for one more question? We had one more in the chat here.
That sounds perfect. One more question sounds great.
Awesome. Thank you. Solomon says, what role should Canada have in aiding the healthcare systems of less developed countries, especially taking into account the international impact of COVID-19?
I mean, it's a critical question. And, you know, as some of you may be aware, there's been a lot of conversation about whether countries like our own are engaging in irresponsible behavior, for example, by vaccinating our youth right now, when we know that the rates of significant, clinically significant illness in young people are so disappearingly low, rather than putting those vaccines back into the global supply so that they can be used through COVAX to vaccinate India, for example. And so the answer is, like, these are incredibly complex ethical issues and problems. And of course, we have international obligations. And we have experienced the extent to which the world is interconnected in this pandemic, haven't we? And I don't just mean because the virus has moved around the globe, although that's certainly true. I also mean that when everybody wants PPE at the same time, turns out to be hard to get your hands on masks. And when the US decides to hoard its vaccine supply, we suffer by having delayed shipments, et cetera. And so the actions of every country have ripple effects in other places. And I think, I mean, I'm not a global health expert. I would say absolutely that, you know, Canada is signatory to many international agreements around how we will conduct ourselves in the global community. And I would begin by looking there.
Thank you so much. There's tons of thank yous coming in here for your time and your expertise. And we so appreciate you having us close off our Insight Talk. We hope you have a great rest of your day as well.
Take care, everyone. Thanks for having me.
Thank you. Just so you guys know, I'm going to stop the recording.